With this, I called our second speaker, Dr. Divya Alex. She's a very well-known and very dynamic VR surgeon of Ahilya Eye Hospital. Dr. Divya, to you, OCT biomarkers and DME.
A warm good morning to everyone. I thank KSOS and Dr. Anubhav sir for giving me this opportunity. So a biomarker can be defined as any characteristic that can be objectively measured as an indicator of a normal biologic process, a pathogenic process, or as a pharmacological response to a therapeutic intervention. So it can be biochemical, molecular, or imaging biomarker. So why run behind invasive molecular biomarkers where you get a live histopathologic comparison in a non-invasive OCT? So anything happening at this level can be illustrated at this level. Anti-VEGF injections, of course, are considered as the first-line therapy for central involving DME. Almost 40 to 50% of the patients achieve significant improvement in BCVA after 1 year of treatment. But there exists another 50%, almost 30 to 60% of patients where edema persists, often with reduced visual acuity even after 6 monthly injection. So the real question is, are we justified in treating all DME patients with monthly anti-VEGF? So at the end of the day, the patient will be only concerned about his vision. Whatever big words you are going to use, he will be happy only if you restore the vision. So the treating physician needs a tailored personal treatment to say or to individualize the disease and to explain the prognosis, what to expect out of the treatment, and if possible, choose the best between anti-VEGF and steroids. For this, you need biomarkers. The most commonly used one is the central subfield thickness. Every OCT imaging software includes an ETDRS thickness map that divides the macula into 9 subfields, and we read the central 1 millimeter. And every newcomer to the field of retina knows that if the CMT is increased, the next step is to inject. But is that so? Because there exists almost 26% of patients with paradoxical visual acuity. That means that even with the raised central subfield thickness, the visual acuity is going to be good. So when you inject and if you get a decrease in the CST, that means that it is a predictive marker, a response to the anti-VEGF. It is not an accurate predictor of final BCVA, although it may statistically looks good. And protocol V have clearly demonstrated that even if it is a central involving DME and if there is a vision of 6 parts or better, observation without treatment, that means even up to 2 years, it can be observed unless visual acuity worsens. So the treating physician needs more of imaging biomarkers to tell the patient. So any DME with a traction or with membranes, surgery will be preferred, and any DME only with inner retinal edema, medical therapy will be preferred. So there are biomarkers that suggest severity and chronicity. Coming to the subretinal fluid, it may be associated with increased urinary protein loss or hypoalbuminemia that can cause an increased hydrostatic pressure that causes retention of the fluid in the submacular region. So almost all the studies, including RESTORE, RISE and RIDE, has shown that the presence of SRF predicted excellent visual outcomes. But recently it has been shown that this SMD is associated with high interleukin 6 levels. That is a feature of inflammation. So there is a recent trend towards greater resolution of SRF after DEXA treatment. That difference is seen more with dex implant even when compared to aflibercept, that is 86 versus 50%. And cystoid macular edema, this has got the worst prognosis compared to that of the other OCT morphologies. The size, location, number of cysts, all are important. And if there is a cystoid and if it is more than that of 200 microns, it gradually compresses the photoreceptor below it, and it causes a negative impact on macular function, and that can result in a worse visual acuity outcome even after anti-VEGF treatment. So more than the size of the cystoid, what actually important is the remaining tissue between the cyst in the central macula. That means that if you compare these three, all are having huge cystoid, but this OCT image, where you have the least remaining tissue is going to have the worst visual acuity. Even after the resolution of cystoid after treatment, it may lead to macular atrophy and profound visual loss. So this can be explained with this image. You need all the 10 layers with the Muller cell, amacrine cell, bipolar cells to transmit a visual impulse. But you see, when there is a huge cystoid, this is what happened. So how do you expect a visual impulse to transmit? And another thing that explains the severity is the bridging retinal process. So if there is a cystoid and you have this bridging retinal process, that is the vertically oriented hyperreflective lines seen within the cystoid, that is good. They are residual neural elements, Muller cells or bipolar cell, that facilitate visual impulse transmission. Absence of this can gradually lead to foveal atrophy. And pearl necklace sign is a sign of chronicity. That means you can see these hyperreflective dots in a contiguous ring around the inner wall of the cystoid. And the significance is that this can be precursors to hard exudate. So when you treat with anti-VEGF post-therapy, you can expect a sudden vision loss because of the migration and deposit of the hard exudate at fovea. And there are certain biomarkers that suggest inflammation in DME that includes the hyperreflective foci, which we call as HRF. They appear as intraretinal hyperreflective dots with the features of size less than 30 microns, absence of backshading. That is how you differentiate it from the hard exudates, and reflectivity will be similar to that of the retinal nerve fiber layer. With progressing retinopathy, this hyperreflective foci will reach from the inner retina to the outer retina. And these actually represent activated microglial cells and is a feature of inflammation. There will be better visual outcome when HRF was absent at the baseline, and initial presence of a larger number of HRF responded better to dexamethasone implant than that of anti-VEGF therapy. And there are hyperreflective choroidal foci also, as I already mentioned. With progressive retinopathy, this hyperreflective foci migrate from the inner to the outer retinal layer. And if there is a disruption of the ellipsoid layer or the external limiting membrane, they gradually shift or migrate to the choroid. The presence of hyperreflective choroid foci, it is a very poor prognostic factor in terms of visual acuity. And there are biomarkers which suggest macular ischemia in DME, the most important being the drill or the disorganization of the retinal inner layers. In simple language, it is the failure to identify the boundaries of the ganglion cell, inner plexiform layer complex, inner nuclear layer, and outer plexiform layer. That means that if you can trace these layers, that means there is no drill. But you see here that you cannot trace this layer. So if there is drill affecting more than 50% of the 1 millimeter, that is associated with worse visual acuity. And in certain cases, DEX implant has the potential to ameliorate the drill. That is, after the DEX implant, it has been found that drill between the boundary of GC-IPL and the inner nuclear layer improved up to 75%, and drill between the inner nuclear layer and the outer plexiform layer improved up to 30%. And ellipsoid layer dysfunction, loss of the ellipsoid and external limiting membrane disruption, it is a feature of macular ischemia, it is a feature of poor functional outcome. That is, if the baseline you have an ELM integrity, that is a good predictor of final BCVA after the resolution of DME. This is one new sign that is called as parallelism that can be found out only by a special software with the OCT. So they compared the subfoveal area covering the photoreceptors, and this was skeletonized using a special software. So if the orientation of the external limiting membrane, the inner segment of the ellipsoid layer, it is parallel to each other, the visual acuity is going to be good. But you see, in a case of DME, if it is not parallel, it cannot be traced, the visual acuity is going to be bad even after treatment. And coming to the choroidal biomarkers, thicker the choroid, there will be thicker the choroid, there will be intact choriocapillaries, lesser outer retinal ischemia, there will be preserved photoreceptors, and there will be better visual acuity. So concluding all, if you have a flowchart like this, you can actually say about the treatment, whether you want to go about anti-VEGF or steroids, whether you can predict the outcome with the severity, with the duration, with the OCT features of inflammation, macular ischemia, and poor prognostic factors, you can explain the outcome to the patient. So these are the biomarkers that help you in recognizing the same. The poor visual outcome will be seen in cases with drill ELN disruption when there is a hard exudate or cholesterol crystals at fovea. Better response to steroids will be seen with HRF, high CMT at the baseline, hard exudates, and drill. So, but always remember that DME is a dynamic multifactorial problem. What you expect, you may not see after treatment. Biomarkers may not always work in tandem. It can be mainly used to explain the prognosis and for a tailored, personalized treatment. Thank you.
Thank you, Dr. Divya, for this excellent talk. Anything from the audience? Sir.
The point here is, you said about inflammatory biomarkers and all that. So what happens is when you give anti-VEGF, it doesn't respond. And then features of chronicity sets in. And majority of these features, if you look, these are all features of chronicity. And more powerful drugs like Dex implant or probably Pegenax, they have a more drying effect. And they work in all these chronic conditions. So what I feel is, rather than these are the inflammatory biomarkers, it just means that in chronic DME, more powerful drugs like dexamethasone and Pegenax works rather than it is the primary treatment. You can
Yes,
look
sir.
at it that
There
way
is
also.
no head-to-head comparison between this Pegenax and Dex, but they have proven this in Pegenax even without.
I'm not talking about comparison with
Yeah.
Pegenax and Dex. I'm saying that drugs with higher drying effect,
Yes, sir.
they have more effect in chronic DME. And whatever inflammatory biomarkers that we are talking, they are all signs of chronicity, and that's why these drugs work better in these kind of
they have proven that whether IVTA have failed,
situations.
Pegenax has been proven better.
Yeah, I mean, that is that if you give one drug, resistance, you give another drug, it works. So that is the main thing.